I'm very happy to share our recent work. It's really the work we published in the last 2 years. Let me share my screen. Okay, so you can see my screen, right?
Yes.
Okay, I will start. So yes, happy to share our work for everybody here. We are a research lab located in Bethesda. We have teams in Shanghai and Shenzhen. We are part of the PAII insurance group. So today I mostly will talk about a full pipeline imaging biomarkers for screening, for diagnosis, and for prognosis. That's basically cover the full spectrum of cancer disease, a very difficult cancer disease. So the following are the hospital we work with. We have other hospital I did not put here, but in general, we are very fortunate to have like many top hospitals in US, in Taiwan, and also in mainland China to work together. So this is, my talk will be a little bit more clinical. And also I thank for Jim's talk. I think Jim actually talked about a few things we share. Even he's most working on brain biomarker and mostly on oncology biomarkers. So this are the building where we're located. So this is the main team about doing the pancreatic imaging, including the management team and also the clinical team and also the technical team. So it's really a multi-disciplinary research environment. So here is actually, I give you some brief introductions about oncology imaging, which I worked for almost 15 years since I joined Siemens. So we have a few like a solid tumor, major solid tumor that's listed here, like brain tumor, lung tumor, liver, pancreas, and colon. In my life, I worked on lung, liver, pancreas, and the colon. So I never really worked on the brain, but I cover most of in the torso, especially in the abdomen. There are a few cases in the clinical workflow. There, I work in Siemens, I work in the hospital. Even right now, I work for an insurance company. So I'm more on the clinical side. So in essence, like technology to enable novel clinical applications to really down to the earth to how to treat the patient, how to impact the lab positively. So there are a few things under the hood. One thing, of course, we all know is segmentation. The other thing is how you translate segmentation and detection into a diagnosis. That means typically for differential diagnosis means that really, what kind of subdisease this patient has, this type of thing. Why it's important? Because the precision diagnosis directly impact, the treatment plan, right? The other thing, which is very important and become more important, is the imaging genomics. It's not just for genomics. It's like imaging, like radiology. I'm mostly working on radiology imaging. Radiology imaging is less invasive. It has some radiation dose from CT, but mostly it's non-invasive, right? So, so a lot of researchers they're working on to map from the radiology imaging biomarkers into the like pathology biomarkers, genomics biomarkers, and other things. Even just look at those textures, those soft tissue patterns much more closely in a quantitative reproduced way. That's also very important. So this is actually very important about the imaging characteristics, because you try to get the DNA sample or you try to get a pathology, that means you have to basically at least do a biopsy on the tumor. So that's more invasive, or even do a surgery. So I think most of the recent efforts have been in this characterization part, but it's become more important. It's about the prediction and prognosis, especially about staging. What's the optimal way of doing staging? For many years, it's the TNM standard, like a tumor grade, nodule, and metastasis, right? This is the metastasis status. So that's basically the recommended clinical guideline. But by no means it's optimal. It's just what we human beings or a human physician they can follow in a reproduced way. So certainly there are a lot of things you can go in there for the more precision, more precise staging, quantitative staging based on evidence. I believe there is you can do a lot of precision medicine there. You can really help patients get a better treatment or more personalized treatment. Another thing, after you get treatment and even on or off the treatment, you will need to see the changes over time of those solid tumors or maybe cancer recurrent or or even like a metastasis, right? So this changing status also is very important about the cancer recurrent and even the treatment response. So in this talk, I will briefly actually cover all of them. I'm trying to. I mean, this lecture is mostly for like a little bit higher level information. I do give you a lot of detail and pictures, but this is really I try to let I know a lot of people you probably do not know the whole picture. I'm trying to cover most of the material based on our recent work. Okay. So in this talk, I will use the pancreatic tumor, pancreatic cancer as an example. Why we choose that is, in US, at least in US, right, the 50% of the medical care spent for the last 3 weeks of the patient care. So when they die, in the last 3 weeks, it's actually very, very costly, right? And pancreatic cancer is relatively rare, but it's not so rare. But right now it's the third leading death in US, and that will be projected to be number 2 in 10 years, right? And the main reason for that, so pancreas cancer, or the major pancreas cancer is called PDAC. The prognosis 5-year survival rate is about 9%, 8%, and recently around 10%. So the first time it become 2 digits, right? So the very reason, well, the key reason is they could not, the patient has no symptom at the beginning, right? When they find it's often like a stage 3 or stage 4. So it's very difficult to treat, and no matter where you are, and it's really difficult. So the key challenge is there a way we can screening for those very difficult cancer, right? We talk about screening lung cancer and other things, but it has no really like much work about screening pancreatic cancer. So this is actually a working summation. So we believe that's the first work really trying to address the in the scale of screening pancreatic tumor using non-contrast CT, because for general population, you don't do contrast CT just to get a screening, right? And also in China and in elsewhere, people do a lot of chest CT, right? For whatever reason, maybe for lung nodule, maybe for some other reasons, right? So the most of the chest CT covers the majority part of the pancreas. And so, but from the right picture on the top, right? So I'm not sure if you can see my cursor. So from the non-contrast CT, actually, it's very, very difficult. Even if most of the time it's impossible for human reader to find if there is a PDAC tumor in there, right? I cannot see it. But from the bottom left, this is a enhanced CT. Human reader actually can see it, right? So we're basically trying to let the machine or let the AI or whatever you call it, it's basically a segmenter, or it's a detecting back segmentation way of doing like a screening cancer to identify it. So on the top right is actually the segmenting output by the machine. It's trained in a way like we transfer the mask, physicians annotated on the contrast enhanced CT, right? Because human beings, a human reader, you could not directly annotate it from the non-contrast CT. Of course, all the patients, we have the ground truth. Like we have the diagnosis report, we have the pathology report, and so their status are certain. So so we really screening, we really like for opportunity screening means like for all the chest CTs, especially non-contrast chest CT, we'll run our algorithm trying to identify a potential T2 or T3 pancreatic cancer patients, right? When they're at T2, mostly they're resectable. And if we can catch them, we perform the surgery right, we can increase the survival rate to 25% to 50%. And the interesting, Michael is not about talking about the technical details, but there should be a publication very soon. We put on archive, you can see it. That's basically using a hybrid transformer, but we do have other segmentation algorithm. The hybrid transformer seems to work better. We have really high accuracy in terms like a 95% sensitivity and 95% specificity. This is very high compared to how difficult it is for this problem, in a very challenging imaging domain. So here is, you don't really need to worry about like how machine will outperform human, because this is really not means for human readers. This really means like we build subliminal tools. They're helpful. They can be a special assistant for the physicians to identify pancreatic cancers. And the way is also, when the AI found the suspicious patient, they will refer them actually to a contrast imaging CT to be confirmed by human physicians, right? So this is a very complementary workflow. Human and the machine, they will live happily ever after for this problem. So, statistically, on the two class task, means abnormal and normal, like, we are 8% or 8%, then better than the best human readers. And for the three class, we're even higher because, machines are better in the fine-grained quantification than our human beings. So that's basically the philosophy. Nothing to be worried about. This really means to be supplementary to human readers. These are more example you can see on the left. I have no way to figure out, and even for the most experienced physician, they could not see it because machines, they're really good at looking at those 12-bit images. That really capture those 12-bit, like those numerical signatures are much better than our visual cognitive system. So this is the statistic, how many patients we train, and how all the number of reports on the holdout the testing data set. We actually this data set actually covers from 7 hospitals. Of course, under the hood, the most important thing is the segmentation, right? This is a little bit earlier work before the transformer. So basically, the topic about this work I want to discuss about is, what's the way when you have self-collect data, when you public data set, they are actually in different modality, different phase, and they cover different aspects of the patient, and how, what's the coherent way you can utilize them together to train a better segmentation model, right? So my goal here is not about the federated learning, it's really about underlying hood, how you have a self-learning algorithms, involving teachers, student, and the teacher assistant, all together to get a better death coefficient for pancreatic tumor segmentation. Yeah. So this is basically the data set, the statistics we have, and also the previous work we compare against. So this is actually, this is work was published last year in PAII. So this is actually the first work, the death coefficient reached to 70%, and before was mostly 50, 60%, because it's really difficult. And another thing is, like, right now we are at maybe 73, 74. Because I know a lot of like audience are Chinese, so I give a little bit Chinese here. So so the key is here, about starting the ideas of big data weak label. So I gave a talk like I think 3-4 years ago at the GTC about big data weak label. I think to have more real patient cases are the key, no matter how you utilize it. Because I don't, because human body are very, very complex and high dimensional, right? It's very, very difficult, if it's not entirely possible. You can do data annotation, but I do not think you really can simulate a lot of novel disease. So this is basically the data set we have here. So you can consider like a data set B and data set D are actually the public data set. And the A and the C are what we collected. And data set A is annotated, and data set C is not annotated. So basic way is we trying to infer the labels, the pseudo labels on data set C using a self-learning case, then reiterate the training process and using the pseudo mask, and you can increase the reliability or fidelity of the pseudo mask over line. And also another important thing is to find the PAII much better is you don't only just need the tumor itself, you also need the organs and vessels surrounding. I believe like Professor Murray did a lot of work about the vessel inside the organ and around the organ, right? I remember his early work around that line. So it does help, yeah. Yeah, so then this is actually the third part of the talk. So I give you a little bit, so this is actually into the precision diagnosis or differential diagnosis. Let's say we found some suspicious PDAC, right, or pancreatic cyst. In general, you can call it pancreatic cyst. Pancreatic cyst can be here terms as it contains up to 10 subtypes of malignant and benign pancreatic lesions, right? And they're actually not very rare. You look at the picture on the left, right? So it's actually grow within the age, right? If the people is up to 60 years old, so it's kind of like altogether it's about 4 to 5%, right? 2.9, 4.0, 8.7. So this number grows, and also Asian risk-wise, Asian is the higher risk population for whatever reason, it may be genetic. We don't know precisely what's the reason. And when people growing older, we are going to have aging society. So we do have more cyst patient, more pancreatic cyst patient, and especially for Asia, for people in Asia, Japan, China, Korea, and maybe even South Asia. So it's a growing, very important like a population health problem. This is the CVPR paper will be present in a few months later. So on the left, this is basically we redraw the picture we learned from the Science Translational Medicine paper from Hopkins. Hopkins has a world-class like a pancreatic cyst center, clinical center. So there are up to 10 types of malignant and benign tumors. And PDAC is about 85 to 90% of that. So the majority are PDAC. They will under different kind of like a treatment, right? When the physician or the machine find a cyst inside the pancreas, or sometimes they can grow outside the pancreas a little bit. The first question they need to answer is, what is it? Is this a PDAC or not, right? So this is the majority question trying to answer. So from the clinical treatment wise, there are three choices. So one is to evaluate if they are resectable or not. If they're resectable, go to surgery, right? So and for other three types, CP, IPMN, and MCN, they have a significant opportunity, or they have significant probability growing into malignant, but they're not, right? So this is why you need to classify into high grade or low grade. Some low grades, they never become a cancer, or they have very low risk to become cancer. You don't need to resect them. You need to classify if they're high grade. Yes, you will do a surgery. And for one spell, one tab is just really like a benign ICN, and then the patient can be discharged. They don't even need to be follow up closely according to the current clinical guideline. So another thing is like a over treatment, right? So you can see is that's actually from the statistics of the John Hopkins like published article. So about 25% to 78%, it varies from different institutes, right? Under surgery, they actually later found that they are not malignant. So it means that they are not necessary to be performing surgery. They should not be surgery, they're benign. They should be monitoring or discharged, right? So I think most of them should be under monitoring. So you can save a lot of, because the surgery and the dissection resection is actually not very good for the patient. You don't want to, you don't want to go a surgery for a patient who does not really need it, right? So this work is the first, the Hopkins work is really brilliant, and that was published in 2019. That's a sophisticated process that I think, or we think, can only be done in the really high level, really sophisticated medical institution. It cannot be performed elsewhere, typically. So our method is address the similar problem, but using or medical imaging, or really, just purely imaging method. The ways we're trying to see, how far we can go just using a pure imaging protocol, right? So our work is mostly on the model underlying is called SMCN. So this basically is nothing really fancy. It's about first you do the segmentation very well, as we explained from the previous work. Then for the pancreas, we actually convert the mass into meshes, and also we can participate the mesh into different anatomical parts of the pancreas, right? Then we actually model the relative geometry from the tumor we found against the anatomy and the anatomical parts. So basically, we know their location, compared to pancreas head, pancreas tail, pancreas body, or which part of the pancreas head and body. And also, of course, we collect we collect from the convolution the feature maps. We collect from the feature map. We do the pooling, local pooling from those vertices on this graph. This is basically a graph convolution neural network, right? So this is similar to what Jim was using, but maybe we are just at a much finer scale to really capture the pancreas variations. So in general, we achieve very similar, like go to the next slide. So this is the protocol we use. So as I explained, I will explain a little bit later about how Hopkins was using. So we use pure imaging. We have a more sophisticated imaging protocol for this differential diagnosis, right? Say we find the suspicious patient from non-contrast, then we refer them to do a 5-phase CT scan, and from there, we try to help to do assistance about the differential diagnosis, really the PDAC or not, or other type of pancreatic tumors. So this is a little bit of detail about how the graph looks like. It's actually a figure in the paper. It's already on arXiv, so you can refer from there. Now this is a little bit more specific about the segmentation, right? Everything we do, the segmentation is still very important underlying. So our model, the geometry-aware model, we capture the autonomy, parts, mass, all these kind of geometry and the texture informations. It helps segment much better for the non-PDAC tumors, right? So from the previous work, almost all the work are working on PDAC, not on the non-PDAC. But this is the clinical needs. We need to differentiate PDAC and non-PDAC. So we do need to work on that. And our model is significantly better, especially on the non-PDAC mass segmentation accuracy, right? So the DAS improved from 48% to 61%. And also, the detection rate is also much higher, from lower than 70% to close to 89%. Yeah. So this is the statistics about the PDAC and other 9 types of tumor we collect. Of course, really great is how we get this data set, right? So this 1,661 patients is really like we have amazing doctor, we have amazing clinical partners to work with. So we really can advance the science, the clinical, and the technology altogether to provide a better clinical solution for the patients. And this is arguably the most important slides in this work is about, because this is directly clinical relevant, right? The doctor really, they care, but they don't really care about much about, how accurate you do segmentation. They do, but it's not direct actionable. So this is actually direct actionable clinical decision, discharge, monitoring, or surgery. We generally did a very comparable result compared to Hopkins, and arguably all these are more unbalanced, so it's a little bit harder. But in general, we say it's similar. So the Hopkins one is really the street art. You can see the beauty of human physicians, the beauty of the top line clinical center, how they perform the precision diagnosis for the patients. Unluckily or unfortunately, most of the people we cannot be treated in Johns Hopkins, right? So they use these clinical features. On the paper you can see what's called clinical feature imaging characteristics. Those imaging characteristics are actually manually performed by the radiologist at Johns Hopkins, and also the cyst fluid genetic DNA sequencing. So it means they do have to get some fluid, from the cyst by doing a biopsy, and they need to do a DNA sequencing, right? This is expensive, and also the tumor can have heterogeneity. The DNA sequence is not always reliable, and also some like a chemical wet lab, markers in there. And our way is really more translational. You perform those 5-phase CT scan. It's not that hard, and many of the places you can do that. And then AI basically can do most of the work after that. And of course we need to improve how the AI and the human integrate workflow, and how we make the result explainable to the physician. It's working on the line. It's working in progress. We have some exciting result on those clinical trials. So other we're doing computer vision medical imaging. This is basically the picture I want to show is basically, this is how our algorithm will perform. We basically propose a probability about, how the machine think, what's that, and also where's the mask. We hope this way can assist the physicians. So we did a little bit like a preliminary like a trial. So we only have one reader that's really, he's really the expert, and we're comparable, basically comparable to the machine result. This is I move to the third part. It's about the prognosis. What's prognosis about is answer those questions, right? So assume we find a PDAC, and then we ask questions: is this PDAC resectable or not? Right? Or should we do a surgery or not? That's the next question to ask. Then, if the surgery answer is yes, right? Then you want to see is preoperative, means before the surgery. Can we do a direct surgery, or we need to have a chemotherapy to make the tumor a little bit smaller or more resectable or safer to be resected? The surgery criteria is really mainly about the location of the tumor versus the vessels near about it, right? If the tumor is the vessel, some major vessels is in general considered as non-resectable, but some top line surgeon they actually can do it. But still, that's more empirical, right? So to answer this question is, before, is that will be optimal solution for the patient to do a chemotherapy before the surgery, or this patient can be sent to direct surgery? And also, post-operative means like after surgery, should the patient be followed up with radio chemotherapy or just chemotherapy? All these questions right now it's actually, it's a little bit more, of course, the physician try the best the way they can find answer for the patient, but we humans is not optimal because this is, it's a lot of guessing in there. There's a lot of guessing, empirical guessing in there. And here is really, we provide a quantitative biomarker, which is highly desirable for personalized treatment with high reproducibility. In clinical, we often emphasize on reproducibility. It means like a intraoperative process. It means like, how this biomarker can be generalizable from one hospital to other hospital effortlessly. I mean, you don't really depend on the special talents of the physician in one institution against the other. Consider you have the top line world-class institution, but most of the patients are not treated in there, right? So how we can improve the top line physicians, and also this result can be translatable to other a little bit smaller or lower grade hospitals where the patient can get a very similar quality of treatment, right? That's the goal. That's the how we make technology more useful for the patient is really for this reproducible precision biomarkers that can help as many as patients as possible. So that's really the goal. And underlying who you have some novel structures about the network. This is not really the focus of my talk here. And here you can see is we do segmentation. We do like segment a lot of peri-pancreas structures around the tumor and around the pancreas. And so the network actually know all these segmentations that were performed. And here is we use a multitask learning compared to, that's how machine think about, how to deal with this problem. Sorry. So this is basically how the poor or the good overall survival looks like. So human, our work is actually designed from the human beings, from the human physicians, right? They actually they do have a hypothesis. Sometimes they guess what's the poor a good overall survival rate, means how long they can survive. Basically, that's basically the KM curve, right? So there are two things. One thing they guessing is about the tumor attention correction, means how dark they are, how bright they are, how inhomogeneity they are within the tumor, right? Of course, based on manual segmentation. The other thing is after resect the tumor, they will go to a pathology exam and trying to see the cells if there are any like malignant cells on the tumor margin, right? If they are the tumor cells, they call R1. R1 is R0. Of course, of course R0 means like they have better survival.
Dr. Liu, we're running a bit over time. Could you finish up soon?
Well, I'll finish very soon. Yeah.
Yeah. So basically, this last slide to explain how the thing work here. So basically is the patient. Basically, there's 3 patients here, and one patient is more deadly. Basically, is higher risk. But you want to have an algorithm which basically can tell them apart before the surgery. About say, the patient 1 is actually they have higher risk, they have poor overall survival rate, and patient 2 and patient 3 they have better survival rate. So basically, the algorithm the neural network trying to do is really produce some biomarkers which enable us to stratify the patient so they can undergo a different treatment plan. And this is also show we compare to the traditional radiology radiomics biomarkers where clinical statistically much better. And of course, this can generalize to other tumors as well. That this is OPSCC. That's a very popular tumor in the Asia area, especially South Asia. Is oral pharyngeal cancer, OPSCC. And also we show is our marker can generalize well among like 9 institutions across the globe, basically in Taiwan, in Canada, in US, in Netherlands, and also in mainland China. So this is also how we visualize the machine result to give feedback to the physician. And I'm done. So I just I just play this video to see this is about the how the tumor how we find the tumor response, how we find the longitudinally, how we monitor the tumor growth, and how we assist the physician to make a decision about the treatment plan, the treatment response, or the monitoring, how you're monitoring the tumor longitudinally. So that's end of my talk. I just let this video play. If you have questions, I can answer, or if you do not have question, we'll move on to the next speaker. Thank you.
Thank you, Dr. Yu. I have a quick question. Could you comment on how the clinicians, radiologists and pancreatic specialists, how have they received this kind of work?
How did you see? Oh,
how did they like this kind of work? Are
they love it.
Yeah.
They love it. Yeah, they love it. We build our things not really to replace him and really do the work they do not want to do, or they feel it's critical. They have trouble to do it, and so it's really about supplementary. It's really about we doing something physicians want, but they cannot do very well, or they do not want to do it, or it takes too long time. They could not do it for each patient to the care to the level they should deserve, basically. Yeah. So it's very all the work here we do is the physician told us what to do, not us to decide what to do. Yeah, it's really trying to address their real need. Yeah, it's about service. We work with them very hard, very we really want to enable them basically to serve patients better. Yeah. Is that answer the question? We of course we do a lot of we do like a larger scale clinical trials to how to model how they interact, how the human physician, how they interplay, how they use the machine result. Yeah, but in general, this is actually the task they ask us to do. Yeah.
Thank you. It's a really impressive collection of work.